Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam, or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is Treatment of Rheumatic Diseases for MRCP, Biologics. Biologics are usually given intravenously or subcutaneously, and they are given after failure to respond to DMARDs, which we discussed in the previous episode, or analgesia, and this depends on the disease, and that includes the number and the type of drug that has gone beforehand. For example, in axial spondyloarthritis, a patient will have tried 2 different non-steroidal anti-inflammatory drugs before being considered for a biologic therapy. The first type of biologics which we will be discussing are the tumour necrosis factor inhibitors. So to be more specific, these are TNF alpha blockers, and the examples of these which are used in clinical practice are adalimumab, certolizumab pegol, etanercept, golimumab, and infliximab. The treatment and initial monitoring are both done in secondary care, and indeed these prescriptions are produced from secondary care as well. There are wide-ranging side effects, the most pertinent being infections, including reactivation of latent TB, which we'll talk about in just a second. Demyelination is a risk, as well as malignancies and congestive cardiac failure. With regards to TNF alpha inhibitor use and TB, it's really important to check for active and latent TB beforehand, and then monitor for infectious diseases, including TB, before, during, and after treatment. There is an increased risk of TB and/or reactivation during treatment, and this can be life-threatening when on TNF alpha blockers. They are contraindicated in active TB or indeed any other severe infection. The next set of biologic drugs are the IL-6 inhibitors, and these include tocilizumab and sarilumab. The side effects also are immunosuppression, and they should not be used in the presence of diverticulitis. Other biologics include IL-17 inhibition, including secukinumab and ixekizumab, as well as IL-12/23 blockers such as ustekinumab. Going on to some other biologics, the first one is rituximab. So this inhibits CD20 on B cells, and an example of an indication for this would be severe rheumatoid arthritis, for example, where a patient has not responded to several DMARDs or other biologics, or actually where they may have a contraindication to other biologics. So a classic example of this might be in the presence of interstitial lung disease. The side effects include infection risk as well as a pneumonitis in rare cases. Cyclophosphamide is an aldophosphamide cleaved to an active alkylating agent, phosphoramide, mustard, and aroline. It is used, for example, in the induction of treatment for vasculitis. Side effects may be tested in the MRCP examinations and include hemorrhagic cystitis, so it's really important to give the drug Mesna with this particular immunosuppressant. Another side effect may be the onset of pneumocystis jirovecii or PCP pneumonia, and therefore it's really important to give cotrimoxazole prophylaxis alongside this. There is generally an increased infection risk as well as with most of the biologics. So now it's time for some questions. Question 1. A 40-year-old lady presents with acute shortness of breath, pulmonary infiltrates, a new AKI with proteinuria, peripheral neuropathy, and a vasculitic rash. She is diagnosed with an ANCA vasculitis and receives induction therapy. 2 days later, she notes new hematuria and suprapubic pain. Which of the following drugs is the most likely cause of her new symptoms? So the options in this case are rituximab, methotrexate, mycophenolate, IV methylprednisolone, or cyclophosphamide. So we have learnt in this particular episode that cyclophosphamide does increase the risk of hemorrhagic cystitis, which is why we give Mesna with this particular drug. So in this case, it's likely that perhaps Mesna was not given and she's now developed hemorrhagic cystitis, which would account for her symptoms. So the correct answer is E, cyclophosphamide. Question 2. What is the mechanism of action of rituximab? Anti-TNF, anti-IL-17, anti-CD20, dihydrofolate reductase inhibitor, or a COX-2 inhibitor? So the correct answer here, if you remember from an earlier slide, is anti-CD20. Just to go through the others, anti-TNF inhibitors include examples such as infliximab and adalimumab. Anti-IL-17 includes secukinumab. Dihydrofolate reductase inhibitor is methotrexate. And COX-2 inhibitors will be discussed in the next episode, but do include drugs such as celecoxib. Thank you for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in future. See you in our next episode.